welcome everyone to this last observatory webinar before the summer break. Today we'll be talking about broadening pharmaceutical services in primary care in Europe, a key policy intervention which is really needed to strengthen primary healthcare and reorient our health systems towards primary healthcare in Europe. My name is Deepa Rajan with the European Observatory on Health Systems and Policies. I'll be moderating this webinar today with my colleague Erica Richardson. And inspiration for today's webinar has come from the Medicines and Pharmaceutical Services chapter of a publication we recently launched called the Primary Healthcare Primer. The link to that will be put into the chat box. We're absolutely delighted to have the lead author of that chapter as our keynote presenter today. That's Sabine Vogler, the head of the Pharmacoeconomics Department at the Austrian National Institute of Public Health. And she will be kicking off this webinar with an overview of how access to pharmaceutical services can be increased. And she'll be doing that through the lens of a Levesque framework on access, or an adapted version of that framework, which is presented in that chapter. And that framework gives us the dimensions of affordability, availability, acceptability, and appropriateness. And we'll be looking at that in terms of pharmaceutical services. And that chapter is a literature review, including grey literature, which has examined what countries have tried and tested and are still trying and testing in this attempt to broaden pharmaceutical services in primary care. And following that framework presentations, we'll hear from countries. We'll get a bit of a reality check. We'll be moving away from sort of the more literature-based theory to real life and practice with speakers from Portugal and Belgium. And they'll give us insights on current issues and discussions on these topics that are happening in those countries. From Portugal, we'll hear about the slow and steady, but strong and incremental investment that's been happening in broadening pharmaceutical services over the last 2 decades. It's been a long journey with inevitable highs and lows and successes and challenges along the way. But that has really placed Portugal at the forefront of the experience with an expanded role for pharmacists and promoting greater links between community pharmacies and primary care services. So we'll be hearing a bit about that. And then we'll also hear from Belgium, where some cutting edge work really is being done on unmet need. And we'll hear how such evaluations, looking really at what the needs are in communities, can help sort of tip the conversation towards how pharmaceutical services and health services in general really can be oriented much more around the needs of people and patients and of society at large. And so keeping needs at the center rather than feasibility or even profitability when it comes to innovations in health. So without further ado, we're going to kick off with a small audience poll to see what you all think about this topic. I'll hand over to my colleague Erica, after which we'll directly hear from Sabine of the Austrian National Institute of Public Health.
Yes, hello. Thank you very much, Deepa. Hello, everyone, and welcome to this webinar. Yes, a quick audience poll just to get a feel for where we are. First question, simple yes, no question. Are pharmacies taking on a greater role in providing primary care services in your country? But then multiple choice question to get into a little bit more of the details. It's how have pharmacies been contributing to primary care? So has that been around supporting the appropriate use of medicines, education programs to foster health literacy, providing vaccinations, point of care testing, none of the above, or indeed all of the above? So really looking forward to hearing about what's going on in your countries. Please do put any questions, comments in the chat box. That's where I'll be for most of the rest of this webinar. Thank you very much. See you later.
Thank you very much. I hope that you can see my screen. Otherwise, please shout in between. Thank you very much for inviting me to talk here. And also thank you for the introduction. This allows me to also move quicker on with the introduction as Deepa has already announced in her introduction, I'm going to present a chapter in the primary healthcare primer that's on medicines and pharmaceutical services. And I co-authored this chapter with Christine Leopold from Utrecht University, Fatima Sullivan from University of KwaZulu-Natal in Durban, and Veronica Wirtz at Boston University. And the nice thing is all my three co-authors and we are working at institutions which have been nominated as WHO collaborating centers. And I also acknowledge the financial support of WHO for this chapter. So, what's the link between pharmaceuticals and primary health care? Already in the Declaration of Alma Ata, it relates that the provision of essential drugs is an important component of primary health care. But at that time and in the earlier decades, medicines, drugs were seen rather in a commodity approach or an infrastructure approach, but this approach had been expanded over the years. So today we have now more an understanding of a broader understanding of vaccines and vaccines, and they are now accepted as community-centered pharmaceutical care, which includes medicines, vaccines, and pharmaceutical services. And you may now ask, what is pharmaceutical services, which is a term that really is mentioned quite often in that chapter. So pharmaceutical services relate to a range of activities that aim to ensure patient and commodity access to medicine. So you hear here, it's not just the individual patients, but we have put a community-based approach, and it includes conventional pharmacy services, but goes beyond, such as further activities, vaccination, medicines use review, and what is important, it involves several health professionals, pharmacists included, but also others. We all know that patient access and community access to medicines is key and important, but there are several challenges which hamper them. In the book chapter, we took a global perspective, but several of these aspects are also relevant in the European region. I just would like to mention a few. For instance, medicines are not affordable because they are not in the public funding or high co-payments. They might not be available to shortages, or not, maybe they are prescribed in hospitals and not in primary care. There is limited patient knowledge and hesitancy of individuals or community, which may limit acceptability, or medicines are not appropriately prescribed. And you see here the access dimensions, which Deepa also referred to. They are based on one of the access frameworks. We took the Levesque one, and it's important that all these dimensions are addressed to ensure patient and community access. So what can now policymakers do to improve access to medicines in primary care, and how can they use a primary health care oriented approach to improve access? You see here quite a number of measures and approaches. We clustered them to these access dimensions, which was not always quite easy because there are certain overlaps. We could discuss the clustering. And I will not, for the sake of time, present all measures, but a few selected ones. And let me start with the affordability part. So we know that catastrophic out-of-pocket payments for medicines are a major issue, even in Europe. So you see here a graph from the Barcelona WHO office, and out-of-pocket payments for medicines in outpatient on average account for more than 1/3 of in households with catastrophic payments. So this is something to be considered. So what can policymakers do? They can prioritize medicines to be included in public funding, and when doing so, also involve patients, for instance, including them in coverage decisions, including them, for instance, in reimbursement commitments, but doing this in a very meaningful way. And more in general, to have health systems that are more needs-driven, and my next speaker, Charline, will also talk about that. Even if medicines are included in public funding, there might be co-payments. There are different types of co-payments. The graph is just to put something there to showcase you. We have the prescription fees, the percentage co-payments, and several countries have several co-payments in parallel. But different co-payments have different impacts. And so for policymakers, it's important to take those type of co-payments that do least harm, and also to consider exemptions and reductions for vulnerable groups. And one really good way to ensure affordability is to promote generics use, prescribing, and dispensing. There are different measures, for instance, prescribing of doctors by the international non-proprietary name, or substitution policies. And you just see from the graph here that for generics, it's quite frequently done in Europe that most European countries have one or maybe two, both of these policies. At least for generics. For biosimilars, it's yet coming. The message to take from is, when you do promotion of generic and biosimilar use, think of those that play a role. Think of the patients, of the doctors, and of the pharmacists. And there are different ways to do so, like, as I said, INN prescribing, substitutions, so some legal requirements, but also financial incentives. A lot can be done through educational measures, capacity building, and what is really key, and I will come back to that again, is trust. Trust of health professionals, but also of patients in the medicines, in that case, in generics and biosimilars. And this leads me to other measures, and that is to empower patients, for instance, on how to use medicines. If self-medication is to be encouraged, we need education in patient, but also, as I've said, for generics and biosimilars, and also for improving what we call medicines literacy. So a little bit in line what is health literacy, but now on medicines. And I think the COVID pandemic also showed quite well with vaccine hesitancy what implications this can have. And I talked about trust, I talked about empowerment. What is also key is a good coordination and collaboration between different sectors of a health system, between settings and the health professionals. What do I mean by sectors? For instance, the primary care sector and the hospital sector, they are often not aligned, also because there are different reimbursement systems. And one example to better align them is to have joint reimbursement committees and lists. There's the example of the WISE list in the Stockholm region. But also to have discharge programs. And one example is the discharge medicine service in England, where hospitals refer, when they discharge patients, them to the pharmacy, where then medicines use review is done. And this is not only collaboration, between sectors and settings, but this requires also collaboration between different health professionals, in particular between pharmacists and doctors. Disease management programs would be another example. And as you can see here from the arrow, this also brings me to the very broad area of pharmacy services to be integrated in primary care. And Suzette will then talk in further detail about the range of pharmacy services, and you have seen it in the poll that going beyond conventional pharmacy services, there are many further things to be done, like extended medicines use review, involvement in disease management program, testing, as we have seen, point of care testing during COVID, vaccination, and so on. I would like to bring a last example, and I think that's really also something I would like to put your attention on. That's multi-sectorial approaches. What do I mean here with multi-sectorial? Other sectors than the health sector, and it's really needed to collaborate. Other sectors could be the education sector, the transportation sector, agriculture, infrastructure. I'd like to bring an example from the educational sector. For instance, we know from studies that teaching children use in schools about the prudent use of antibiotics can improve not only their knowledge, but also reduce inappropriate antibiotic use. And for instance, in England, NICE then recommends all schools to teach about responsible antibiotic use. So this brings me to finalize and to conclude. So I'd just like to sum up. The role of medicines and pharmaceutical services has changed over the years, expanded, and patient and community access can be improved. We have seen the examples through a range of policies and actions. It's important to address different dimensions of access, affordability, availability, and also to have approaches that ensure empowerment of patients and communities, ensure integrated health services, and multi-sectorial approach. So thanks a lot for your attention.
Thank you, Sabine, for that insightful overview. You've really walked us through some concrete interventions like, better public funding coverage for medicines prescribed in primary care, as they are a huge, one of the key drivers of out-of-pocket expenses, fostering trust in generics and biosimilars, health literacy, collaboration with other sectors like schools, collaborations between community pharmacies, hospital discharge services, primary care services. These are all really concrete interventions. Let's see how this plays out in practice. We'll be hearing about that in a minute from our country panelists. But first, let's get to the poll results. Erica, enlighten us on that.
Thank you very much. Yes, so thank you for everyone who managed to respond to the poll. Interestingly, sort of 3/4 of you are saying that pharmacies are beginning to take on a greater role in providing primary care services in their countries. And of those services, the really sort of key ones seem to be supporting the appropriate use of medicines and vaccinations, but then also a little bit on point of care testing. So very interesting to hear that this expansion is happening, and it'll be really interesting to see in more detail how this is working in Portugal and Belgium. So thank you very much. Back to you, Deepa.
Great, thank you. So you can see lots happening in countries. Now let's hear directly from Portugal. We'll be hearing from Suzette Costa, who is with the Institute for Evidence-Based Health there. Previously, she's worked for 2 decades with the Portuguese National Association of Pharmacies, directing first the Department for Pharmacy Services for almost a decade, and then another decade directing the Center for Health Evaluation and Research. Suzette, tell us about the Portuguese experience of broadening pharmaceutical services and in communities, and what are some of those key achievements in your view, and the greatest challenges which need to be addressed today? Over to you.
So thank you. I'm delighted to be here. I'm sharing this floor with Sabine, who I've known for so long, and we've worked together in a couple of projects. So it's always a pleasure to be with Sabine, a huge expert in everything that has to do with pharmaceutical policies. Also, greetings to Charline and to Deepa and Erica. Thank you for having me here today. So I just have 5 minutes, but I will try to explain a bit on the expanding of services in primary care in our country. As you know, we have, this is just a brief picture, just to give you an overview. It's kind of a very condensed slide, but it's just to give you an overview of the different patient services that Portuguese pharmacies have implemented throughout more than 25 years. And all has been with manuals, with flow charts, with protocols for pharmacies. So there was material that was shared and sent through our National Association of Pharmacies and deployed in almost the entire pharmacies. I wanted to say at this stage that 95% of Portuguese pharmacies are members of the National Association of Pharmacies. Hence, it was possible to deploy and implement such a huge range of services. But I wanted to walk you through, because Sabine also and even Deep and Erica wanted me to give you a review of how we build up throughout the years. So this is very dense, but I tried to squeeze it in just one slide to give you a timeline on the different milestones that were achieved with governments in Portugal. So these are, you have to bear in mind that this was the end result of all those different actions and which were piloted in small scale projects, then they have built into larger scale projects and nationwide projects. And because of that investment in Portuguese pharmacies, which had a lot of patient care services, always in attempt to communicate with primary care, it was possible to achieve some milestones. I will walk you through without much detail. We can leave it for the discussion. But just to tell you that this adventure started more than 20 years ago with the first pilot disease management on cardiovascular diabetes and asthma in pharmacies. And this was modeled of the Kaiser Permanente disease management programs that were implemented in Colorado by clinical pharmacies. So we got our inspiration from there. And it was actually my first mission when I joined ANF in 1999, and I stayed there until 2019. So all of these started with this pilot. Then we managed to succeed the NHS reimbursement of one of these programs, which was a priority for the country. Diabetes still is a priority area. And we managed to secure this reimbursement until the year before we had to request a financial assistance. And there was a problem, as you know, with our country, and we had to request the financial assistance. So during that period, there was funds available, and these were shared with pharmacies. Then in 2007, we got enlargement, and we got major milestones of the scope of services pharmacies are able to provide in legislation, and that included flu vaccination. And so our team actually prepared for one.
Okay, then what we'll do is, Charline, would you like to come online, and we'll maybe switch around the order. So just to introduce Charline, and we'll get back to Suzette's presentation in a minute. Charline Maertens de Noordhout is with the Belgian Healthcare Knowledge Center, the KCE, and she's worked as an expert there since 2018, and she was part of the team which has developed a methodology for identifying people and patients' needs in Belgium. So Charline, tell us a little bit about why the Belgian government, and it has been really a priority for your government, they've also pushed it through as a priority within its the Belgian Council presidency, and why the Belgian government feels that evaluating unmet need in communities is, and not only patients' unmet need, but also societal unmet need is so important. What do you wish to achieve with this, and how does it work? Tell us.
Hi, everyone, and thank you very much, Deepa, for the very nice introduction. So good afternoon, and I'm very, very happy to give you a very brief presentation of the NEED project today. So we started with the observation that the healthcare system is currently driven by supply and not by the need of the patient and the society. In fact, we see that innovation in health, that can be new medicines, new technologies, new devices, is mainly focused on profits and not on the need of the patient and the society. So it leads to a misalignment of innovation with public health needs. And this observation was also made by of course, the Belgian Minister of Health, and also from several other countries, who then asked us to work on the subject as part of the Belgium's presidency of the EU Council. The consequences of such innovation system are first, of course, the exclusion of many patients from the innovation. For instance, you can see in this figure, this is a figure from a report presented by WHO, that most of the clinical trials are developed in oncology and very little is developed, for instance, in psychiatry, hepatology, or surgery. We also observe that there is little commercial interest beyond drug discovery and little innovation outside pharma. We also see that there is limited impact of current investments on public health and therefore, of course, waste of public health resources. We also observe that even if there is an innovation, it doesn't always add benefits. Look, for instance, at this second figure. This study was carried out in Germany and showed that of the 216 medicines that received market authorization by the EQUIC between 2011 and 2017, 58 demonstrated no added value. So the aim of the NEED is to move towards a more needs-driven healthcare policy and innovation. And to do this, we are developing a database on patient and societal unmet needs in different health conditions. But of course, before developing the database, we developed a framework to define how to estimate unmet needs. So we started from the health condition that can generate, as we call, health-related needs. And this need can be related to 3 domains. Hence, having a good quality of life, healthcare, for instance, accessibility of care, and social needs that are the other needs, for instance, need for education, keeping his job, etc. And this can be at the level of the patient, but also at the level of the society. And for each of these dimensions and domain, we identified criteria of needs, for instance, accessibility, And for each criteria, we also define indicators to estimate if needs are met or not. So, for instance, accessibility of care can be evaluated using indicators as access to care, waiting time, or healthcare out-of-pocket payments as indicator of unmet needs. Then we applied the framework, the need framework for Crohn's disease and melanoma. This is a very few example of results we obtained for unmet needs at the patient level. So as you can see on the first figures for the health needs, we observed that both disease impacted quality of life, and this for all dimensions of quality of life. But you can see that, for instance, for Crohn's disease, we see that pain, discomfort, and anxiety are very, very highly impacted. For healthcare need, for instance, we show that 30% of the patients who are suffering from Crohn's disease did not always receive care when they needed it. And for melanoma, we also observed that 50% of the patients waited more than 3 months before consulting. And for societal needs, what we see is that, for instance, that for Crohn's disease, 48% of the people reduced work or stopped working. And for melanoma, we see also that 20% of people reduced work or stopped working. So this was a very, very short overview of the NEED project, but please don't hesitate to go further on our website and contact me directly by email for additional questions. Thank you very much.
Thanks, Charline. And we've also put that link to the NEEDS project in the chat box for you to take a further look. This is really, a cutting edge piece of work, in my view. You're really charting the path forward towards orienting pharmaceutical services and indeed the entire health systems towards real needs in communities. This is really about people-centeredness. And, coming back to the framework that Sabine presented, we see that matching, people's needs to pharmaceutical and health services in general, it clearly increases access, it's about availability and acceptability and appropriateness. And this is all about, orienting the system towards people's needs. Now, quick question. Do we have Suzette back online? Can we go back to her presentation?
We've not been able to track her down yet. So hopefully she will be able to rejoin soon.
Okay, so in the meantime, let's go ahead and maybe look at some questions. Maybe just to wrap up a little bit, or at least link a little bit to Suzette's presentations. We didn't get to hear everything, unfortunately, and maybe we still will be able to. But you saw that trajectory in Portugal, starting really over 20 years ago, and how they sort of slowly started with the disease management programs with diabetes, then added on vaccination services, then e-prescribing, e-dispensing, and in all of this in the interest of really increasing access of the pharmaceutical services to people, because this is a core pillar of primary healthcare, of strong primary healthcare. And so those interventions really aimed at increasing availability of services in communities, the affordability of services as well, because by having care in communities, by being able to refresh chronic disease medication through e-prescribing and e-dispensing, we also increase the affordability to the system of those services. Of course, acceptability and appropriateness as well. So we heard now from these two countries, but let's hear a little bit from the chat box. Erica, what are we seeing there? Can you give us a brief overview?
Yes, thank you very much, Deepa. I think people are still pondering and questions are still coming in, but a couple of points have been raised. One is maybe a bit niche, but Sabine would certainly be able to answer it. About the role of community pharmacies in clinical trials that are being conducted in primary care. And then a much broader question, which would be the role of pharmacies in the use of digital tech. So sort of the rolling out of digital therapeutics and things like this. Back to you.
Great. Sabine, would you like to take that first question? I think this is a very one that is in great discussion everywhere, the role of community pharmacies in clinical trials. Over to you.
Yeah, thank you very much. So I think the question was very much also related to regulation, where I cannot provide an answer. I think when this is discussed, one should always consider what are the elements that ensure really good primary health care. I did not go into that detail during my presentation, but I mentioned it that it should be linked to the empowerment of patients and communities, and also this collaboration, coordination, and integrated services. So with clinical trials, probably not all elements can be fully maybe met, but certain elements surely. And when this is to be moved forward in that case, I think in particular the patient empowerment with certain elements that I also addressed, like trust, capacity building, and so on, should be taken into consideration.
Great, thank you. And I think that demand side is always really something we need to keep in view, and empowerment, fostering trust, because that really is at the heart of why we have our health system. And I think including and collaborating with pharmacies in these trials is one avenue for that. But I think that's sort of the common thread, I think, in this discussion, and also in terms of what Charline presented with the need framework. We had a question on the role of pharmacies in the use of digital therapeutics. Sabine, would you like to take this one again? And if we have Suzette come back online, this might be one for her as well.
Yeah, I think that's a good question. And I think there is definitely a role with the digitalization that pharmacies can make use of it, also with regard to testing and so on. But I would like to use this question to look at it even at a more broader way, coming to the topic of telemedicine. I did not touch in my presentation on the topic of, or not too much, on bringing medicines closer to the patient. So when we have issues in rural areas where it's quite far away, and here digitalization, digital tools, and can help. I just like to mention the telemedicine. And I think this also has to be thought in a very broad way. For instance, if we think of electronic patient records, and I come back to the area which I mentioned, collaboration between health professionals. For instance, we heard from a country which is quite advanced in digitalization, but that, for instance, pharmacists have only limited access to the electronic patient record, which it means also that they do not have the full picture. But if that would be allowed, and if it would be allowed that pharmacists could add information, then also in this digital world, digitalized collaboration could be fostered.
Thanks, Sabine. That's a really important point, because this interprofessional collaboration, is often the focus is really about that clinical interaction between patients and providers, and interprofessional collaboration to improve that experience. But part of it is really ensuring that all professions have access, as you say, to electronic medical records, and have the same information base to go on to improve patient experience. And I think here we also have telemedicine, which has been accelerated through the COVID crisis, and has huge potential to really bring care to people's homes, and to bring care closer to patients, which is ultimately what we want, in our health systems with the strong primary health care. Erica, any other questions that we're getting from the chat box?
Yes, it's getting a bit lively, but some really, really interesting and good quality questions coming in. So when we talk about the need to know, when we talk about the expansion of pharmacy services. What do we need to think about in terms of for those countries that potentially don't have such a really expanded role for pharmacy services in primary care? What are the pitfalls? What do you need to look out for? The sort of like the sort of like what needs to be avoided, sort of advice that you would give. A really interesting question is also, does the expansion of primary care services being provided through community pharmacies, does it actually relieve pressure on primary care? So because that's often one of the driving factors in the expansion of this policy. And a question for me, because I'm really interested, what next? It's expanding at such a rapid rate. What do we see as the future for this? Where are we going to go next? Where are the exciting innovations going to come from? So thank you. Maybe we'll get a third round in.
Great. Thanks, Erica. And thanks. Great, Suzette, to see you back online. We're just taking some questions. And I think one that we could maybe direct at you, sorry for putting you on the spot right when you get back, but there's a question around, for countries who haven't started expanding pharmacy services, where should one start? Where should the priorities be? And while defining those priorities, what are the pitfalls and the challenges that one should anticipate in that process? Over to you, Suzette.
Sorry, I don't know what happened, and I don't know how much have you seen of my slides, but trying to answer to the question, I think, there is just no magic solution, and every country is a different situation. One of the slides I showed was exactly when you want to invest in collaborative care. It's very important to begin that work in close collaboration from scratch, because it is oftentimes pharmacies have some services they provide, and that's fine. It's part of their business model, because pharmacy is a profession that embraces community pharmacy both. So it's not within the public system, it's a private also a business unit, so it has its own business model, but it also has a place within the NHS and within the healthcare systems. And therefore, there should be a dialogue from the beginning, and to start with pilot projects, but really trying to build that collaboration. It's not so much about what you as a pharmacist would like to do, because I often see many articles and many papers that publish randomized controlled trials, and we keep on publishing the same randomized controlled trials, and we are actually making a big case of getting the evidence on things that already have evidence. Like we know for a fact there are some interventions that they have a major efficacy already proven, and if you make a comparison with the pharmaceutical industry, they don't run trials over and over again to prove the efficacy of a product. Once is proved, is established. So then the next step would be how to then best really invest in implementing these services and building from the trials, but trying to adapt it with the primary care. Interoperability between systems is key. And without that, I find it very difficult to have some sort of collaboration between the two entities.
Thanks, Suzette. So really that message, I think, is loud and clear. Build collaboration. If anyone starting to expand on pharmaceutical services, make sure that collaboration is there from the beginning. Build on it, build relationships between primary care services, hospital care and hospital discharge services, community pharmacies and pharmacists, and and start from there. And that will be sort of that basis, that foundation for everything else. Thank you, Suzette. You did mention something that I think is very interesting on the fact that the trials that we have and the evidence that we get sort of brings us in, takes us around in circles without moving us forward sometimes around. And that links to what Charline presented on how, a lot of the information and the studies and the investments is not really based on needs, but is unfortunately, based on other issues and other priorities. Charline, did you want to comment on that? It's linked to your first slide.
No, so as I already presented, the problem indeed is that the system is mainly supply driven. And so, of course, the innovation is mainly based on the profiles. But we also see that there are more and more medicines who are coming earlier on the markets and with sometimes bad data. And so we think really that it's very important that pressure is put it on clinical industry to develop and to present data like quality of life, because sometimes they are using some proxy of data. So this is a bit the issue, but of course the NEED project was not only based on pharma solution, because for instance we see that because this is of course for pharmacies, but sometimes the solution is not a medicines, but it can be a prevention policy measure, for instance. So this is not only medical. So the idea is just to say, okay, we have a disease, and this is where the unmet needs are. And this is not specially, the solution is not specially a new medicines. It can be, of course, a new, better health policy, better prevention measure, something like this. So this is a bit the idea. And so what we would like is to just drive the innovation not only on pharma, but also another type of solution.
Yeah, no, that's really, really key. And I think it's important, this insight that, if we're driven by need and unmet needs, we need to acknowledge that sometimes, the solution might be, as you say, in prevention services, but that means that we want our pharmaceutical services to be targeted where the need is, and for other services to then be targeted where that need is, and that's where, we gain efficiency in times of less and less funding going to health. So really key insights. Thank you, Charline. We had a question on that Erica just mentioned. Does expansion of pharmaceutical services actually relieve pressure on primary care? Who would like to take that one? Any insights? Sabine, Suzette?
Maybe I start off and Suzette can give then maybe even more insights, because I know that Portugal has also done some studies about that. I think we have seen that it may relieve pressure, and I think it also has, again, to do with the collaboration. It's not just the pressure on the system, but also the pressure on healthcare workforce, where, I mean, we are all aware about the problem. And if, for instance, then is a meaningful expansion, maybe it's the word expansion could be rephrased by its expansion, but also that services are offered, or new collaboration models are offered, and then it helps, for instance, GPs to focus on their specific role, because other tasks are taken over. We now talk about pharmacy services, but we could, of course, also talk about other task shifting in primary healthcare. And for some evidence and studies, I know that Suzette has done some in Portugal, so I hand over to her.
Yeah, can you just briefly repeat the question, because I had some problem.
No problem at all. So basically the question was, does expansion of pharmaceutical services, does it actually relieve pressure on primary care services? What are your thoughts and experiences on that?
Okay, so I think that is a huge area for investment because during the pandemic, certainly if there was doubts, there was proof that pharmacies were able all over Europe, in some countries more than others, but they were able to relieve the pressure on the NHS by taking care of people that did not have face-to-face appointments in the NHS. So our patients in Portugal, they were for more than 1 year without having a physical medical appointment with their doctors, but they would go to the pharmacies. So because the pharmacy stayed open. And so that was a huge public health service, I would say, because these were the people who were monitoring patients while they were not being, physically seen by doctors. And there were so many issues these patients were facing, chronic medication patients. So I think there is a lot more we can do to kind of relieve the pressure, to prevent unnecessary emergency room visits. So why do we have a problem in our country, and I think in some countries, that patients, they put the pressure on the healthcare system by going through emergency care visits. In some of these situations, they're totally unavoidable. They're totally avoidable. We can actually, if we have shared protocols, let's say shared pathways, care pathways, then we can manage these patients and we can prevent them from going unnecessarily to emergency room exits. And there is proof, because we know that there are ambulatory care sensitive conditions, and so these are the conditions that we would expect to have patients better treated to avoid the use of emergency care visits. So I think we can do a lot more in screening and triage, and not just referral, but actually we can have some treatments provided directly to patients without the need to get a prescription if there is a shared care pathway that has been pre-agreed on a local or national or regional level. So that would be my, because there is a lot to do on that area to relieve the pressure on the NHS. But then let me add, I don't think it's just on relieving the pressure, it's also the efficiency of the system. Like, for instance, why is it not possible to have in between medical appointments, to delegate some of the monitoring of chronic disease patients in pharmacies? So they don't need to go every 4 months to the medical appointments. They would probably, the vast majority would require to go there maybe twice or once a year, and they could be managed in pharmacies with direct communication to the providers, and then leave the most case management and complex issues for the physicians, for the GPs. So there is a lot to do there. And for instance, patient adherence in first-line therapies. Why are we increasing costs on NOACs, on novel anticoagulant oral therapies that are so expensive to our healthcare system, or diabetes medication, when a few patients or some patients probably can go very well with first-line prescription drugs like metformin, like warfarin, under close monitoring. So we would decrease costs for the healthcare system. So there is just so much we can do. I mean, this is just some examples. I don't want to take too much of your time, but these are just some examples where really we can bring efficiency to the system as well as relieve the pressure.
Yes. So the short answer is yes, we can definitely, there's huge potential to relieve pressure on primary care services and emergency room admissions. And what you said, Suzette, also goes back to what Sabine said about, each of the, multi-professional collaboration, which allows each professional to really provide their added value to the system where their training really comes in best. So we want GPs to really focus on some of those complex patients and other professionals to help, for example, with the monitoring of chronic disease patients, which just really is a great improvement, not only in efficiency, but also in patient-centeredness, because we increase access then for patients to services. And so ultimately, we come back again to collaboration, to new collaborative models, to more sharing of information and discussion and interaction between the different professionals. We have just a few minutes left, but I wanted to pick up on that question that Erica brought up. Where are we going with this? What's the future? And maybe I'll start with Charline here, because what you're doing, Charline, is really cutting edge. I see it as really the pathway for future work in this area. What are your thoughts?
So for the NEED project, of course, in the next few weeks, we will publish the NEED database. And the idea is, of course, that this database can be available for all actors. So it means pharmacists as well. It can be for political. So I think that's also for pharmacists, it can be a tool to see, okay, what are the needs? What are the needs of the patient depending on the health condition? So we really hope that this tool can be useful for different type of health professional.
Great, thank you. And this is really what other countries should also be moving towards. And we'll be closely watching some of your evaluations, Charline. Sabine and then Suzette, can you give us your thoughts on what's the future in this area? Where do we need to move towards? What do we need to prioritize?
Well, I think these ideas of primary healthcare with patient empowerment, with collaboration, these are to be prioritized. And I think also with COVID, there is a change in mindset. It was seen how important it was. For instance, with pharmacy services, we see that even countries that have more traditional roles are interested, there's appetite to move that way. We will see what will happen in practice, but still I think that the train kind of started running, and I really hope that there will be more PHC related principles to be accepted in healthcare.
Great, thank you. So more community thinking, needs-based thinking, primary healthcare, linking to pharmaceutical services. Suzette, over to you.
Okay, just briefly. So I think the next or the investment in future I would love to see is actually to build on a clear protocols and clear delegation of tasks, because oftentimes we have duplication. And we have pharmacies sometimes doing things, but they are doing on top of what the primary care is doing, and that is not efficient for the system. So I think whoever is at the healthcare system needs to think that there has to be a coordination and actually trust and delegate some of the tasks, so that you actually take time of the providers, of primary care providers, and you delegate some under a controlled environment. So these are, let's say, the cases that you can manage on a daily basis, and you can perhaps delegate to pharmacies to allow them to screen, test, and treat. For instance, to monitor patients in between medical appointments. High-cost therapies. It's not just generics. Generics are important, of course, to ensure affordability, but also there is a lot of waste in high-cost medication that is dispensed solely in the hospital. So I think pharmacies can do a lot more in ensuring adherence and ensuring no wastage in high-cost therapies that cost so much the healthcare system. So I think these are some of the areas that really need to be, and then interoperability. I don't think any of this will be possible without the software systems communicating, of course, with patient consent. So there has to be a clear investment. In our country, we have this ready in our pharmacies. We do have, everything was ready until the communication, but the problem lies on the primary healthcare system. If it's not prepared to communicate and really exchange data that is useful for the GP or the nurse, and then for the pharmacist too. So I think interoperability between systems is a major advance to be promoted.
Thanks a lot. So again, we come back to collaboration, and that means clear delegation of tasks between those who are collaborating, and IT systems and software to really support that. So thank you very much to our speakers, to our audience. I'm sorry we weren't able to take all the great questions that came up in the chat box, but this recording will go online. We do have a number of publications in this area, also in our medicines work streams that you can look up on our website, European Observatory on Health Systems and Policies. And but without further ado, I'll let you go now, and we'll see you after the summer break. Thank you very much.
Thank you. Bye.